doctors. On behalf of Merck India, I am Juhi Gupta from the Oncology Marketing team, and it's my pleasure to welcome you to the first MedChat of 2025. We are truly honored to have a distinguished panel of experts and international faculty with us today. A special thank you to Professor Pa Arisa for joining us to share his invaluable insights. I would also like to extend my gratitude to Dr. P.N. Mohapatra sir for graciously agreeing to chair today's session. We have a well curated agenda for the next 1 hour 30 minutes. Yes. So, with our esteemed speakers today, the agenda flow will be like Dr. Rajat Saha sir will be presenting on the epidemiology of NLCLC and rare mutations in India, followed by Professor Pa Aris sir will be addressing the unmet challenges in MET exon 14 skipping NSCLC, which will again be followed by Dr. Darshit Shah sir, who will be discussing the Indian experience with TETMEDCO through a case study. Then we'll have a panel discussion wherein Dr. Akhil Kapoor, sir, will be moderating today's panel discussion, which will include our expert panelist, Professor Pa Aris, sir, Dr. Murtada Bora, sir, Professor Dr. Brigadier S. Vishwanath, sir, Dr. Darshit Shah, sir, Dr. Deepak Kumar Shukla, sir, and Dr. Arun Warrior, sir. A big thank you to all our esteemed speakers, moderator, and expert panelists for their time, expertise, and contribution to today's session. Your insights will definitely be valuable to everyone in attendance today. So, without a further ado, I would now like to introduce our chairperson, Dr. P.N. Mohapatra, sir. He actually needs no introduction, but to mention that he currently is the director and head of Department of Medical Oncology at Apollo Multispeciality Hospital, Kolkata, with over 28 years of experience. His extensive background includes affiliation with AIMS, Kasturba Apollo Hospital, AGHL, and much more. He earned his MBBS degree from AJ Institute of Medical Sciences and Research Center, Mangalore, and holds a DM in clinical hematology from AIMS, New Delhi. Dr. Mohapatra sir has been part of numerous national and global clinical trials and specializes in treating patients with chemotherapy, targeted therapy, immunotherapy, and CAR T cell therapy. So, with this, Dr. Mohapatra sir, we invite you to say a few words before we commence the session. Over to you.
Thank you. Actually, I just an MBBS, MD, and DM, and actually met actually previously when we are testing everybody actually for lung cancer targetable mutations, and met was not mane, either the testing methods were not picking up properly actually. So slowly, MET inhibitors came. The testing methods, both DNA, RNA, and the testing methods. Now, actually, we test at the beginning for any MET exon speaking mutation. And if somebody, fortunately, we have a MET exon speaking mutation, we give the option of tepotinib or capmatinib, both. So, this is actually the percentage. It is actually maybe 2%, 3%, but what we are seeing is very less. We are doing a lot of tests, but we are seeing very less actually. But I think they are very exciting molecule, and we have given patients, and the response is good. And the only problem is edema, but I think we need a broader discussion, especially with a person who is a authority in lung cancer, Professor Luis Aris. And I think I will not take much time. It is a long discussion. I will bet to Mark. So the flow of this session will start. And
Thank you so much, Dr. P.N. Mohapatra, sir, for setting the context. We now move to the next part of the agenda. Can we move further? Yeah, thank you. So now I would like to invite Dr. Rajat Saha, sir, for taking us through the next session. And to begin that, I would also like to introduce him. Can we move to the next slide, please? Yes, it's my honor to introduce Dr. Rajat Saha, sir, who comes with a great experience in the oncology space. He's a senior consultant and unit head medical oncology at Rajiv Gandhi Cancer Institute, Delhi. So, Dr. Rajat Saha, sir, over to you.
Thank you, Juiji, and I thank Mert for giving us the platform to discuss this rare mutation, but definitely a very actionable mutation in the field of adenocarcinoma lung. And now that we have got very good molecules for the target also, so we definitely would like to test more patients and give them that advantage. So I'll be speaking on the epidemiology of lung cancer in India and also what is the landscape of the molecular alterations which is seen in India. So uh, you would be projecting the slide, or should I share the slides from my side?
Sir, I'm projecting from my end.
Okay, fair enough. So I can just give you the instructions.
Put Dr. Mohra one. Mohra को एक बार mute कर
ये मुझे बताइए कि अपने को तकलीफ में क्या बहुत पहले yes sir, do I need to change the slide?
No, I'm
Yeah,
saying mute
I think so. There's a
Mohra
lot of
को.
static noise at the end of Dr. Mohta's. Yes. Okay. Thank you
Yes,
very much.
doctor,
Thank
please
you.
continue.
Yeah. So next slide, please. So this is the global disease burden of lung cancer, and we all know that in the current clinics we are seeing the non-small cell lung cancer accounts for 80 to 85% of the lung cancer cases, with adenocarcinoma subset being the most common histology. According to the Globocan 2022 data, the incidence of lung cancer stands at around 12.4%, and the deaths are proportionately higher at 18.7%. The Indian lung cancer data, as per the Globocan 2022, the Indian incidence of lung cancer stands at 5.8%, and the deaths stand at around 8.2%. India is the fourth highest contributor of lung cancer globally after China, US, and Japan. And it is the second most common cancer in males and seventh most common cancer in females. Next slide, please. So this is the ICMR study. On the left hand side panel, we can see the 2004 data, which is the years missed because of lung cancer. So here, lung cancer stood at 10th position in 2004. And as per the 2021 study, it's now stands at the first position. So definitely there is an increase in the years lost due to lung cancer. Next slide, please. So this is the molecular landscape of lung cancer. Lung cancer is definitely not one single cancer. On the left-hand side pie chart, we can see the bifurcation as per in the adenocarcinoma subset. We have got only 20% of adenocarcinomas which are nowadays characterized as wild type. That means they have no actionable mutation. And rest, approximately 80% do have some mutation, some driver mutation, like KRAS is there, EGFR is there, BRAF is there, MET is there, ALK is there, ROS is there, and NTRK and HER2/neu. Amongst the squamous cell carcinomas, about 55% are classified as wild type, and only about 20% have some FGFR1 mutation, and about 12 or 13% patients have PIK3CA and PTEN mutations. So overall, yes, we can see that adenocarcinomas are quite driver-driven cancers, and hence the opportunity to treat these cancers in a very much personalized way. Next slide, please. So this is the overall how we have evolved in the labs as far as the diagnosis of lung cancer is concerned. We started with a single entity called as lung cancer. Then we moved on to non-small cell and small cell lung cancer. Then we moved on to adenocarcinoma, squamous and small cell lung cancer. Then we moved on to the molecular pathology. Then we added on the PD-L1 expression levels also into it, and hence on the right hand side panel, we can see that we definitely have a host of targeted agents which we can use in these adenocarcinoma of lung. Next slide, please. So now when do we test? Earlier our thought process that we used to test for all these molecular markers at progression. But again, this has very much changed in the field of lung cancer since last around 7 to 8 years. We are kind of assessing almost all patients at the first clinical presentation for all these molecular markers. And this is a data from the US whereby they have said that about 79% of the patients are subjected to the molecular testing at first clinical presentation rather than later on. So that is almost a picture again in our clinics also. If and when we do get the opportunity, and we definitely ask the patients to get the molecular markers. Here we may differ as per the area of practice and the scope of practice. Sometimes we do offer only EGFR, ALK, and ROS. Sometimes we do offer proper NGS comprehensive genomic panel analysis, which covers other genes also. Next slide, please. So now, over time, the concept of liquid biopsy has also evolved. So liquid biopsy does pick up CTCs. It does analyze the cell-free DNA, the ctDNA levels are there, and we can subject these cell-free DNAs to the same testing methodology like RT-PCR, like NGS, like IHC, like FISH. So in the tissue biopsy, definitely we offer IHC and FISH, but in the liquid biopsy, we can offer RT-PCR and NGS. So definitely we are getting a good validation, a good concordance between the tissue biopsy and the liquid biopsy, and tissue is currently not the major issue in lung cancer nowadays. Next slide, please. So I had told you, do we do sequential testing? Do we test for EGFR, ALK, and ROS initially, and then go on to the other markers, or we do an upfront comprehensive NGS panel which covers all the 12 to 15 actionable mutations? So this was a paper from Rajiv Gandhi, Dr. Ullas Batra has presented. So they commented that compared to the sequential testing in EGFR, ALK, ROS negative patients, upfront NGS testing resulted in additional 1.2% of patients with actionable alterations for targeted therapy. So that means 1.2% patients additional will be caught by NGS. The turnaround time for NGS was a median of 14.2 days, and the cost increment was definitely there at 19%. The detection of complex EGFR alterations, variant ALK fusions, and ROS fusions also improved by the use of NGS. Additionally, squamous histology patients also depicted the MET exon 14 skipping mutation and the KRAS G12C codon mutations in 2.4% and 4.7% respectively. So hence the justification of probably using NGS, if the resources are permitting, we should use an upfront NGS because we are able to catch about 1.2% extra actionable alterations at a slight increment of cost. Next slide, please. So this was a paper by Agarwal et al. Published in Pathology, and they analyzed about 552 patients, and 57.9% patients had a minimum of one genetic alteration. So 58% patients are having one major actionable genetic alteration either in EGFR, ROS, BRAF, MET, and ALK genes. And MET and BRAF mutations were more common in the elderly population, and EGFR mutations, ALK and ROS rearrangements were more prevalent in the younger population. So this is a very large data set, which is saying that approximately 58% of the patients do have some actionable mutation. Next slide, please. So this is a paper by Amit Rotan et al. From Bangalore, and they have said that they have analyzed the genomic landscape of NSCLCs in India using the circulating tumor DNA, so ctDNA analysis. And here they analyzed about 120 patients, and here they found that 28.6% patients had EGFR alterations detected on the liquid biopsy. 9.8% had a ERBB2, HER2 alteration or mutation. 3.6% patients had a KRAS mutation. 5% patients detected a MET mutation, MET amplification, or MET exon 14 skipping mutation. 1.8% and an ALK mutation. So definitely this paper proves that even on liquid biopsy analysis, we do definitely get a sizable population of patients who can be targeted by one molecule or the other. Next slide, please. So what is the value of adding on liquid biopsy to tissue biopsy? So we generally start with the tissue biopsy. If we have a tissue biopsy, we definitely prefer the tissue biopsy. So what is the value of doing both? So molecular alterations by conventional testing was found in 39 patients, and 61% patients were negative. So 37% of the 53 conventionally tested negative patients were subjected to blood NGS panel due to logistic reasons. So out of those patients, 70%, that means 14 out of 20 had detectable mutations on the blood NGS. So that means if we are testing the tissue of 100 patients, if 61% patients are negative, now if we subject those 61% patients to a liquid biopsy, we will be able to find a mutation in 70% patients. So hence, this paper by Ashwath et al. Showed the value of adding a liquid biopsy and its ability to pick up a mutation which is generally missed on our conventional tissue biopsy NGS. So that is a very interesting observation, and we probably, if the resources permit, we should supplement our tissue biopsies if it is negative to by a sequential liquid biopsy. Next slide, please. So to summarize our Indian data in this field of biomarker testing in NSCLC, India is the 4th highest contributor of lung cancer. Molecular testing assists in the selection of targeted therapies. NSCLC biomarkers can be tested via tissue or liquid biopsy, and it can, in the coming years, serve as a complementary method also. Recent Indian studies have documented the prevalence of driver mutations in Indian NSCLC patients, and more studies on a larger cohort of patients can be done. We have the ability, and we do detect certain mutations even in squamous cell carcinomas also. So hence, I would say that even non-smoker category of squamous cell carcinoma should also be subjected to the comprehensive NGS panel to pick up an actionable mutation. And thank you very much, and looking forward to the guest lecture by Dr. Perez.
Thank you so much, Dr. Rajat Saha, sir. It was great to hear from you the NSCLC landscape in India. Now moving forward with the next topic in the agenda. Yes, can we move forward? So I would now like to take this moment to actually request our guest speaker or international faculty to take us through this topic of tackling the unmet challenges of MET exon 14 skipping NSCLC. But before that, can we move forward to the introduction? So, Professor Pa Aris, we are truly honored to have you with us today. For those who wouldn't be familiar with Professor Pa Aris, sir, he is a globally recognized leader. Can we move forward? Yeah, he's a globally recognized leader in lung cancer research and treatment. He currently serves as chair of the Medical Oncology Department at Hospital Universitario 12 de Octubre in Madrid and head of the lung cancer unit at CNIO. Additionally, he holds the prestigious role of president of ASEICA. With over 340 peer-reviewed publications in top journals such as NEJM and Lancet Oncology, Dr. Pa-Aris sir has played a pivotal role in shaping global therapeutic strategies. His groundbreaking work in lung cancer and thoracic oncology has significantly advanced personalized treatment approaches. Beyond research, Professor has served on esteemed scientific committees influencing international cancer policies and clinical practices, which includes ASCO and ESMO meeting scientific committees, the European Organization for Research and Treatment of Cancer Protocol Review and Audit Committees, the Spanish Agency of Medicine and Medical Devices, and the European Medicines Agency. Additionally, he is also the Chief Medical Officer of the AECC, where he also serves on the board. Professor Pa-Aris sir, we greatly appreciate your presence and insights, and the stage is now yours.
So thank you very much, Yuhi. This is my great honor to be here. And I really thank as well, not only Merck, but also the nice introduction to the scene by Dr. Saha, and also the chair of this meeting. So I was wondering if I have can I have my slides and can I move them forward? So
Sure, doctor.
Can you give me the control, if you don't mind?
Yeah, for sure. Kushi, can you please let Professor present his slides?
Yeah, sure, ma'am.
Okay.
Yes, Professor, you can share your screen.
Okay, I think that's fine. So sorry. Okay, 1 second. Oh, sorry. It's gonna be 1 minute. Here it is, me. Are you able to see the slides?
Yes.
Okay, wonderful. So over the next few minutes, I'm gonna share with you some of the data and my views on tackling unmet challenges of MET skipping non-small cell MET skipping 14 non-small cell lung cancer. So I'm pretty sure you're familiar with the MET receptor, which is one of these typical tyrosine kinase receptor, which sits as a protein transmembrane, having an extracellular domain where the ligand is binding. In that case, HGF, hepatocyte growth factor, is of course having a just membrane domain, which is important in terms of regulation of the activity of the next domain, which is the kinase domain. And also this juxtamembrane domain is important to dilucidate the degradation rate into the proteasome. Importantly, when the signaling is active through this receptor, it activates a number of pathways below, particularly relevant, the MAP kinase pathway and the PI3K-AKT, so particularly affecting survival and proliferation. Indeed, of course, it's also having some, let's say, relevance in other important factors, particularly invasion, the motility. You're pretty familiar about this epithelial to mesenchymal transition that is really driven very much through this signal. And in normal cells, it's actually relevant on tissue regeneration, good healing, and embryonic development. Of course, all those phenomena very much related somehow to cancer. So do you really need for ground healing and tissue regeneration, proliferation, and movement of cells to repair the wound, and you need a clearly invasiveness possibilities. In cancer, this relevant receptor can be dysregulated by a number of reasons. We will touch today particularly this MET exon 14 splice alterations, but there are some other possibilities, and could be overexpression of the receptor or overexpression of the ligand, amplification, which may lead to the overexpression in terms of protein, could be mutation of the kinase domain. Those typically do not happen in lung cancer, or at least are rare. The more frequent one we are talking today among the mutations is the exon skipping mutation. And then there are some cases in other diseases of MET fusions as well, as we have already mentioned. And that is the focus today, the MET exon 14 splicing mutation. In normal circumstances, when the DNA is read to a pre-RNA, of course, it's going to require some loss of intron fragments. And normally, that is what happens with the normal splicing. These intron areas are lost, and you see what the result that you see below is the typical normal sequence of the MET gene. What happens when there is an aberrant splicing mutation? What happens is that you're not only losing the intron parts here, but also, in addition, you're losing exon 14, and then in the sequence of the gene, you're not having exon 14, and that is very relevant because in normal circumstances, exon 14, which is this juxtamembrane domain, is relevant for a number of things. It's relevant because, as I mentioned you before, it's having some regulatory activity in the kinase activity. It's actually somehow helped to regulate the kinase activity, and is somehow inhibiting the kinase activity of the kinase membrane. And on the other hand, is favoring the degradation, the ubiquinization of the receptor. So by those two means, exon 14 is actually decreasing the activity of the MET receptor. So you're having this splicing mutation. At the end, it results in higher activity of the kinase and lower degradation, and overall is a clear increase in the MET activity. I mean, you look at the aberrations, and Dr. Saha had already commented on that, depending on the geographical region, but overall, some 3 to 4% of the patients with non-small cell lung cancer do have alterations in MET, what we call the exon 14 skipping mutation. And already we have strong data suggesting that this aberration should be recognized before starting any treatment, because patients may benefit having this information to guide their treatments. And you look at here, which are the typical characteristics of those patients. Those are not overlapping with other oncogene-addicted aberrations. You see here that patients that are smokers always are at risk of having this mutation, and is not only having in adenocarcinoma, but also in squamous cell carcinoma. In fact, some 30% of the patients in maybe non-adenocarcinomas. Particularly relevant, you're having a sarcomatoid tumor, the rate of exon 14 mutation could be as high as 25%. So just importantly, it's not only happening in adenocarcinomas, it's also happening in other possibilities, in other histologies. Well, once the tumor, the aberration is being recognized, and once we know this is inducing oncogene additivity, it's been a real interest on developing true inhibitors of this gene. And to inhibit this receptor, a number of possibilities do exist. One could be small molecules, particularly inhibiting the kinase activity. can be more or less specific. And you see here the first generation such as crizotinib, more advanced generations such as capmatinib or tepotinib, and there are some other possibilities. That is also depend on if they are type 1, type 2, and so on. And then you also can have monoclonal antibodies that bind to the ligand or to the MET receptors and may even be biospecific, such as the case for amivantamab, or having a payload producing an antibody drug conjugate, such as the case for Teliso, biospecific drug. In terms of, you look at how this information is now being used in the clinic, you realize that nowadays most of the international guidelines acknowledge that having the information of genomic aberrations such as EGFR mutation, ALK, RAS, and so on are very important, and they include MET exon 14 mutation as a relevant information to know before the patient is treated, before treatment is started, because the treatment should be based on the knowledge of those genomic aberrations. Indeed, you look at the ESMO guidelines, and of course, they do recommend you have an exon 14 mutation treatment with specific inhibitors, such as the case for tepotinib or capmatinib, and of course, the ASEAN Thoracic Oncology Research Group as well do have a recommendation which is aligned with NCCN or ESMO. One of the important questions, and doctors have already alluded to, is how can we recognize that? We know that about 15% of the lung cancer tumors are actually never biopsied. They are never biopsied because biopsy is difficult, or you try to do the biopsy, you may get some cells, but not enough material to molecular testing. In some other cases, the family alluding to a poor prognosis, or the patients don't like to go on with a biopsy, and therefore some good number of patients you do not have tissue to do at least the molecular testing. Thank goodness, as is being mentioned, we have two possibilities of testing here, not only tissue biopsy, but also liquid biopsy. You can use, as today, one or the other, or you may use two. Actually, they are pretty complementary. Doctors are commenting this Indian study where among those patients that were a genomic aberration, actionable genomic aberration was not found, still in tissue biopsy, still they were able to find in some 70% of the cases a genomic aberration actionable in liquid biopsy. We have done such a study. In our population, the number is somehow lower, but still able in some 30% of the cases to find some genomic aberration. The good thing about liquid biopsy is that it's less invasive and is not as sensitive, but is having about 90% of the sensitivity, particularly if it's metastatic, particularly if the disease is out of the lung, and it's particularly true if the tumor mass is enough. So the real point is, as today, we know that the predictivity of genomic aberration found in liquid biopsy is as good as genomic aberrations in tissue biopsy. What happened in the era we didn't have specific inhibitors of MET? We tend to treat those patients with chemotherapy, and truly what happened, those patients were not doing very well. Median survival was always lower than a year for stage 4. And if you compare that to what happened today, for example, with tepotinib, you realize that those results with MET inhibitors looks to be better, I would say. Of course, you cannot do a true robust comparison because those are not contemporary data. If you compare what happened to those patients treated with immunotherapy, you really do have very much the same results. Very often MET exon skipping 14 mutations do have high expression very often of PD-L1. Even the tumor load is frequently low. And what is very clear is that the median PFS with immunotherapy is pretty low in this setting, very low, particularly, in the range of 2 months, 3 months, or so on. And that is clearly much lower than what you expect with a specific MET inhibitor, which is higher than a year for those patients with this mutation if they are treatment naive. And the same is true in terms of median survival with immunotherapy in the range of 1 year. It could be nearly 2.5 years when giving a specific inhibitor. And you should hear comparison of series. This is not randomized trials. This is putting together real-world data of patients treated with immunotherapy, or treatment with a tepotinib in the VISION trial. You realize a huge difference in PFS, and the same is true when you're comparing not to immunotherapy, but to immunotherapy plus chemotherapy. So in the two graphs, there is a huge difference between treating with a specific treatment as compared to chemo-IO. And if you look at survival instead of PFS, again, the data holding true. So altogether, I would say you're having a stage 4 patient with MET exon 14 skipping mutation. The prognosis is worse. Secondly, those patients are doing worse, particularly with immunotherapy or with chemotherapy. And third, it looks like a specific treatment with specific MET inhibitors such as tepotinib may improve the outcome of all those patients. Just for the sake of time, I'm going to briefly mention what happened with the result with the two, let's say, most used inhibitors of MET. I will start with capmatinib here, you see, and we have data of those patients priorly treated with other with chemotherapy, another with no prior treatment. You see here in the cohort of patients that had received 1 or 2 prior treatment, responses are in the range of 40%, and disease control rate 78%. If you go for the patients that didn't receive treatment before, for the treatment-naive cohort, the overall response rate is higher than 60%, and disease control rate in the 95% range. You see again the same result here: 40% responses for pre-treated patients, more than 60% for untreated patients, and I think those data, I would say, are pretty robust. Indeed, as I mentioned before, today, ESMO NCCN suggests that the true treatment, the best treatment for those patients with MET exon 14 mutations is MET inhibitors, and they put capmatinib and tepotinib. I have mentioned to you the data from capmatinib, and I'm going to mention you more in extent the in-depth data from with tepotinib, and those data are based on the VISION study, which is the highest, the largest study with MET exon 14 skipping mutation, more than 300 patients. Half of the patients actually are in treatment without prior MET inhibitors. The other half had already received some treatment before. You do have patients with elderly, more than 75, and I will give you some of the sub-analysis in this case. As I was telling you before, the inclusion criteria in this study needs to have stage 4 patients, exon 14 skipping mutation of MET, importantly, no prior treatment with agents directed to MET, and less than 2 lines of therapy or maximum of 2. And there are a number of cohorts here. The important thing at the end is that out of the 313 patients, half of them were treatment naive, the other half had received prior chemotherapy, not prior TKIs. And as you hear, patient characteristics are, I would say, pretty similar. Still, 1/3 of the patients were Asians, and some 70% of the patients were, some 50% of the patients were male. Histology were more frequently adenocarcinoma, but still some 10% of the patients were squamous. 20% of the patients had brain metastases at baseline, and look at that. Half of the patients were treated without prior treatment, so that was our first line. 1/3 of the patients were second line, and 1/3 of the patients were actually a third line. If you look at here, you realize that smoking history was true in about half of the patients. As I mentioned, Asia was in about, Asian patients were in about, of those included in the liquid biopsy, you see here that in most of the cases where 15% of them were actually Asians, as compared to 29% in the tissue cohort, and I think that's pretty relevant. In altogether, 80% were adenocarcinoma. If you look at the data, I would say 40% of the patients had been included only based on liquid, 42% only on tissue, and about 20% were liquid and tissue positive. So they have data on liquid and tissue. And overall, half in each group were a treatment naive and half were pre-treated. If you look at those patients that were enrolled by the tissue biopsy, in the first line, you realize that the response rate was nearly 60%. More importantly, median PFS nearly 1.5 years, 16 months, and survival was 2.5 years, 30 months. So those are very important data. Remember, 60% response rate, median PFS, 16 months, median OS, 30 months. This is what happened in the same cohort of tissue biopsy diagnosed patients. In the previously treated cohort, response rate was not 60, but 50%. Median PFS was not 16 months, but 11.5, and median OS was not 30 months, but 20 months. So there are differences between the line of treatment, and that may be relevant to remember, so that is not the same doing the biomarker analysis at baseline as compared to doing it all along the natural history of the disease. Importantly, there is promising activity in brain metastases. That is no doubt. The number of patients that had actually measurable disease were not very high, was about 15 patients. And as you see here, a very good number really have a clear intracranial response, 10 out of 15 patients, which means 67%. Most of the patients, nearly 90%, had a disease control in the brain, and the median PFS in the intracranially was more than 20 months, 21 months, and that I would say talks in favor of clear CNS activity. What happened in Asian patients? I told you that some 30% of the patients in the tissue biopsy cohort and some 15% in the liquid biopsy cohort were Asians. You see here, response rates are aligned with the prior data I told you about, maybe somehow a bit better. Response rate 64%, a bit higher than in the, let's say, Western population. Median PFS 16.5, very similar, and median OS a bit more than 30 months. Those, very somehow aligned with the data in the rest of population, a bit higher in terms of OS and PFS. What happened in those patients previously treated if they were Asians? Well, response rate 50%, also a bit higher. Median PFS 12 months, median OS also a bit more, not 20, but 24 months. So altogether, maybe the data a bit better. That is quite frequently to see better data in Asians as compared to non-Asians. There was some analysis also dedicated to elderly people, more than 75 years. And of course, as you see here, responses were very similar, 52% in younger than 75, being 45% in more elderly patients. So not much difference, similar disease control rate. And if you look at the median duration of response or the median PFS, again, were aligned. I don't see there were a difference. So that talks that even elderly patients seems to benefit from that therapy. Safety profile of tepotinib is well known, particularly relevant the edema, hypoalbuminemia, which is, I would say, relevant. And maybe this is a bit higher in elderly patients as compared to non-elderly patients. Remember, grade 3, any grade 3 was more frequent in elderly patients as compared to younger patients, 40% as compared to 21%. Requirement for dose continuation was also double, 10% in younger population, 20%, 19% in those patients elderly than 75. So even safety profile is adequate, you have to monitor a bit more carefully and be ready to institute adequate measures in terms of safety control in those baby patients with exon 14 mutations when treated with tepotinib. Other side effects, apart those related to edema, hypoalbuminemia, include, of course, increasing creatinine. We will mention that. That doesn't mean necessarily the patient is having a decrease in renal function, but just an increase in creatinine, and some GI effects were common, nausea and diarrhea being described in about 1/3 of the patient, and hyporexia in about 1 out of 6 patients, the same for constipation. Okay, what about among those TEPO and capmatinib inhibitors in this patient population? Is there any randomized trial? Is there any robust comparison? I could say no, there is no robust comparison. There is no trials comparing back-to-back one to each other. There are, however, some indirect comparisons, such as this Mike pairwise indirect comparison. You see here, how do they look the data? If you compare in patients that are treatment naive, and you see here in terms of PFS is somehow a bit longer in the Vision study with TEPO as compared to the Geometry study with capmatinib. Median PFS in the range of 60 months as compared to 12 months. If you go for survival again, 30 months with TEPO as compared to 20 months with capmatinib. You see here the data. Important to say, this is not a robust comparison. This is what the best we can do. This is not a randomized trial. Again, you compare the data in previously treated patients, the difference, I would say, numerically, graphically, even higher. Median PFS, 11.5 months as compared to 5.4 months. Median survival, 20 months as compared to 14 months. So the data are pretty, I would say, substantial. Response rate 49 versus 40%. Just to finalize a bit more on MET, we have commented that maybe those patients that were elderly do have a bit more risk as compared of patients that were not that were younger, I would say. Among the important side effects, I would say we have mentioned edema is maybe one of the more relevant ones, but also, as you see here, some GI side effect, nausea, constipation, fatigue are relevant. If you look at all those side effects, I don't think we have seen major difference between the inhibitors, one to each other's, very much in the same. Grade 3 edema in about 10% of the cases altogether, and I don't think you have also big differences in the skin duration range, apart from savolitinib, which is more frequent, but very similar between TEPO and capmatinib. If you look at what to do if those side effects are developing, I don't know how much experience do you have with TEPO and with capmatinib. I mean, you're having edema, you may handle at the beginning, that it tends to be a cumulative side effect. That do not happen in the first month, but tend to happen when the patient is being in months of treatment. And a bit more often happens in elderly population. And the only thing you can do, initially you may try a diuretic. This is not gonna work very much, but it's gonna work for very short time. Then you have to decrease the dose or even interrupt treatment for a while. If the patient is grade 3, please interrupt, allow it to improve, and then restart at a lower dose. If the patient is having grade 4, forget about restarting. Creatinine increase deserves some mentioning because that increase does not reflect a decrease in the filtration rate. That only translate an inhibition of the tubular transporter of that particular protein. So if you measure creatinine, let's say, filtration rate by other means, maybe you realize the filtration rate is not decreased. So therefore, you should monitor that. I think it's important. And you may, if you have, you may measure the filtration rate by another mean. That would be what I would recommend you to do. The rest of the side effects, I think you know them, are very common. And particularly, most of them are related to the management of fluids due to hyperalbuminemia, peripheral edema, pleural effusion, and so on. The rest of the side effects are not particularly relevant, apart from some nausea and constipation that may reserve specific treatment. So just let me summarize what I've been saying over the last 20 minutes or so. I could say there is a clear unmet need for patients with MET exon 14 skipping mutation. This is a small subset of lung cancer, but very important. 3 to 4% of the cases do have this oncogene addictive disease, and we know that a specific inhibition may be modifying the natural history of the disease. We know that happens in patients across different histologies, particularly high among those patients with sarcomatoid tumors. Some good number of patients do have brain metastasis, and that is happening about 20% of the patients at the beginning. You have a number of potential treatments here. I could say capmatinib and tepotinib are among those recorded. I would say tepotinib on non-randomized data may be at least as good, if not better, than capma, but that is based on non-randomized comparison. And of course, your increase in response rate, PFS and OS. Remember, first line, a PFS exceeding 60 months, survival exceeding 30 months, response rate in the range of 60%. Important to know and to monitor the more relevant side effects and do supportive care and adjustment of the dose or even discontinuation when needed. This is an appropriate treatment even for elderly population. So thank you very much for your attention. I'll be happy to discuss any potential question on any controversy I may have created. Thank you.
Thank you so much, Professor, for this insightful presentation and sharing your global perspective also, which matches the Indian context. So I would now like to move ahead on the agenda. And Dr. Khushi, if you can share the screen. Thank you
Yes,
so
ma'am.
much.
Yeah.
Yeah, thank you. So now I would like to invite Dr. Darshit Shah, sir, to take us through an Indian experience case study with TETMEDCO. And yeah, can we move forward? Yes. So it's a privilege to have you, sir, on board. And Dr. Darshit Shah, sir, comes with an experience as a consultant medical oncologist. Can we move behind? Yeah. At And he practices at Sir H.N. Reliance Foundation Hospital and Research Center. So, Doctor, over to you now.
Thank you for your kind introduction. Can you please share the slides from your end?
Yeah, we'll do.
Correct. So we'll be discussing the Indian experience with TEPMEDCO. Next, please. So MET dysregulated NSCLC is associated with poor prognosis. We all of us know that patients, population defined by MET exon 14 skipping mutations, typically elderly, and may be challenging to treat due to comorbidities. In a vision study, Tepotinib has an overall response rate of 54% in patients aged less than 75% and 54% in more than 80 years. And disease control rate of nearly 67%. That's a very, very impressive number. Next, please. So this is a compilation of 6 cases. Patient ages were 54 to 82 years. 3 males and 3 females were there. Adenocarcinoma histopathology and ECOG of 0 to 1. All patients received tepotinib once daily after the KGs were reviewed and discussed within a multidisciplinary team. Next, please. So these are 6 cases. All patients with zero. We can see that patient number patient number 3 and patient number 5 had exon 14 skipping mutation, and the other had MET amplification. Next, please. So this is a 83-year-old female with MET exon 14 skipping mutation, diagnosed with a stage 4A with smoking history. Pre-treatment scan showed this. The patient opted for tepotinib, and we started her on tepotinib. Next, please. So post tepotinib of 14 months, we can see the scan showed tremendous improvement, and the patient was clinically also better. Next, please. Clinical outcomes in patient with EGFR mutated advanced NSCLC. So we can see that the median treatment duration was 8 months, and we got this is a patient the patient number 5. This is patient basically on tepotinib since 14 months, and the most reported adverse events were pedal edema, which we see in majority of our patient, but the patient response was very good. We can also see that the patient had received previous treatments like osimertinib, and when they had met amplification, that's the second line we put it on tepotinib. Next, please. Next, please. So, thank you very much for your time and patience listening. Thank you so much. And thank you for giving me the opportunity.
Thank you so much, sir, for taking us through your Indian case study. I would now like to invite Dr. Akhil Kapoor, sir, who is a professor and a medical oncologist at Tata Memorial Center, Varanasi. And sir, it's a privilege for us for you to moderate the session. So can you please take it forward from here?
Yeah. Thank you.
Thank you.
Can you allow me to share the slides?
Yes. Dr. Khushi, you can stop sharing.
Yeah.
You can share the slides, sir.
Yes. So after the talk by Professor, it has become much easier for me for conducting this panel, and I look forward to get some of the real world comments and real practices, because we have seen the data, and I think all of us are very convinced about the data, and there's no doubt about that. MET inhibitors like tepotinib, Tepmetko is one of the best possible treatment which can be given to a patient with MET exon 14 skipping mutations. So I will invite my panelist. Dr. Ayers is already there, and we look forward to him for giving expert comments as always. Dr. Murtaza, and Dr. Vishwanath, Dr. Rajat Saha, Dr. Darshit, Dr. Deepak Shukla, and Dr. Arun Warrior. Hopefully all are there, and we can go ahead now. Yes. So this has been covered actually, and initially when we had discussed, we thought that MET exon 14 skipping not so common for us, but when we started doing RNA-based NGS, situation suddenly changed, and we get a significant amount of MET exon 14 skipping mutation now in our practice. So I will first take a comment from Dr. Arun. Dr. Arun sir, do you think RNA-based NGS has changed the incidence in your practice? What do you think, and what has been your experience in terms of testing?
I think we have been testing for a long time, but I think nowadays we are picking up more. The percentages are increasing. Liquid biopsy, we are still not started very much. So I think it is going to increase with the more liquid biopsy being available. So definitely it's more.
Thank you. And we get a lot of sarcomatide carcinoma as well. Dr. Darshit, can you comment on sarcomatide carcinoma, where we see somewhat higher incidence of MET exon 14? If Darshit's unable to comment, I will request Dr. Deepak.
Yeah, so in the sarcomatoid variant, there is the means enrichment of this MET exon 14 skipping mutation close to seen in 20-30% of these patients.
Yeah. So what we see, sarcomatide carcinomas, we tend to see one in every 7th, 8th, or every 10th patient in our practice is sarcomatide carcinoma. It's a good number actually, and that is we identify sarcomatide carcinoma. Our pathologists are able to identify sarcomatide carcinoma more commonly, as it was being highlighted by Dr. Deepak. MET exon 14 skipping mutation percentage is definitely much higher in sarcomatide cancers, increases from 4% to at least 14%. Sometimes data is for 20% as well, I agree, but 14% is the ballpark figure which we take. Dr. Ayers, do you agree with this comment of around 14% skipping mutation rates in sarcomatide cancers?
Is to me the question?
Yes.
Okay. So yeah, I mean, there are some variability between the cohorts. I think typically the cohorts are not very large, and it depends on the type of test they use. I have seen as high as 30% and as low as 10%. So I could say maybe 20% is a good average, I would say.
Okay. So I think all of us agree that at least it is more than the usual of routine adenocarcinoma. That is what we come to consensus, and it is between 10 to 30. Average can be 15%. So completely agree. So whenever we see sarcomatide cancers, our antenna lights up actually, and we try to find that if we should not miss MET exon if it is there. So let's move further ahead. And we have seen these data sets already. We'll come to some of the relevant points. Now, some relevant discussion about adeno versus commerce. So initially, the paradigm was to test EGFR, ELK in adenocarcinoma only. Then the paradigm changed to testing NGS in adeno. Later, guidelines came that we should test NGS in all cancers of either it is adeno or squamous. So if we see that this data of vision study as well, around 80% were adeno, rest were not adenocarcinoma. So here I would like to get some comment. Dr. Murtaza, I request your comment on this point and requesting your expert comments.
Definitely, as initially we used to do NGS only in the adenocarcinoma. Now, as the clinical scenario of its young female, sometimes non-smokers, still having the squamous histology, or many times smokers smoker but squamous and in a true cut biopsy, we definitely go for NGS because now we have many targets which many mutations which can be targetable. So I think in our routine practice we all generally practice squamous cell as well as adeno.
Correct. Completely agree. So as it was being highlighted, it's important to test not only adenocarcinoma but also squamous carcinomas. And we, in fact, we started testing first for EGFR, and we have our own publication of EGFR testing results and therapeutic targets, therapy with EGFR targeted therapy in squamous cell cancers, and we published it back in 2017. And in fact, NCCN guidelines came much later, and they were updated later on after 2019 to suggest that yes, squamous cell carcinoma also require testing with panels like this. So I think it is with experience we have also learned and agree that yes, squamous cell cancers also have targetable mutations, though the incidence would be slightly lower, and but it is not to be missed. So I think the guidelines also suggest the same now. So now these are the various exon 14 exon MET alterations to be and it includes not only exon 14 skipping but includes amplifications as well. Fusions are not common. I think that is not well important. Some point mutations. Now we are talking about exon 14 skipping mutation, but we are discussing about RNA based test to detect it. How this dilemma is solved? I request Dr. Vishwanath, sir, if you're there to give your expert comments for the benefit of the various attendees who might be the residents and trainees so that they can understand the basic. Dr. Vishwanath is there? Else, I will look at Dr. Rajat.
Hello, sir. Hi, Dr. Darshit this side.
Yes, Darshit. Please go ahead.
Sir, usually we see exon 14 splicing mutations commonly, and we usually use NGS for all our patients now.
Yeah. So why do you think RNA-based NGS is important? Initially, DNA-based NGS is cheaper, RNA-based NGS is costlier, and this is a mutation. But we are looking for an RNA-based test for mutation. What do you suggest? What do you think? Why it is happening?
The sensitivity is better for RNA-based NGS, and I think that's the reason, sir.
Yeah.
I would like.
So sensitivity is better, and what happens in RNA-based test? It is exon 14 skipping mutation. That means exon 14 is completely deleted actually. So what happens? The exon 13 and exon 14 get fused together. They come together, so they will be detected by RNA-based test much easier because we are detecting a fusion, which is slightly different from the routine fusions and routine activity. And DNA-based platform, you can see there's a point mutation for deletion of exon 14. So I think I've tried to make this point very clear. This is a type of mutation which is much better detected on a fusion-based testing. That means RNA-based testing, unlike other mutations. So this is a catch, and this needs to be taken into account. So it's very important, and I think with time we understood this, and the data is also very clear, and that is why RNA-based testing is very, very important to be covered. So again, let's come to liquid or tissue biopsy. I think it was being covered in short by the previous panelist as well. Dr. Deepak, any comments on tissue-based versus liquid-based testing in your practice? And do you think our liquid-based testing is sufficient whenever it is feasible?
If we have adequate tissue, I generally start with the tissue-based NGS. Possibly, if the tissue-based NGS turns out to be negative, and in a clinical scenario where a patient is possibly a non-smoker female, in that setting, I usually combine or send liquid NGS means also.
Okay. Completely agree. So, Professor Ayers, I require your comment now. So, do you consider doing both tissue-based and ctDNA-based testing together, or do you reserve it for a sequence?
Okay, I'm telling you, we just finalized one analysis just recently published in JTO. So we analyzed some two cohorts of about 300 patients each, where we did always tissue biopsy with an NGS at the hospital, and concurrently we did a standard panel of liquid biopsy. Half of the patient had a Guardant Health test, and the other had a Foundation Medicine test. The data were very equal. So you find one genomic aberration in one test is not worthy to repeat. If you start with liquid, it doesn't make sense to do it again. You always get in the same result. But if for some reason the test do not work, there is no enough RNA or DNA or whatever, some technical difficulties, then go for the complementary. And third, you have a test that was well performed, but you didn't find any aberration, you should always look for the complementary, because maybe in 10% of the cases, not 60%, as our colleague Dr. Saha mentioned in this small study in India. In our case, was only 10 to 15%, but still, it's important. You find 10 to 15% of the patients with a complementary test that are having actionable genomic aberration is always worth it. At least this is. So therefore, what we do is we start typically with tissue biopsy, and if it's negative, we go for a liquid biopsy.
So that's very important and relevant comment which we got from Professor Ayers, that do a tissue-based testing if it is feasible. Tissue is the issue most of the time, but yes, most of the time we are able to get tissue at least in the first line setting before starting the treatment, and then you can go ahead with the tissue-based testing. And if it is negative, you can find some additional 10 to 15% of targetable mutations and fusions if you're able to do blood-based NGS. So I think that makes sense, and that is what can be done to optimize the resources, because we all live in a world where resources are limited and we need to optimize the resources. And the tissue is negative, definitely go for blood-based NGS. And if tissue is not available, definitely there's no other option to go ahead with liquid biopsy. Now, coming to liquid biopsy in the second line settings, for example, when the patient has progressed on EGFR TKI, it's another area which we require some very additional and specific comments. So, Dr. Vishnath, I request first you to give your insights and comments. Second line testing, we always try to get tissue, but it's very common that patients either refuse it, or if the progression is at such a location where you cannot biopsy it. Then do you think liquid-based NGS is useful?
See, first of all, in second line setting, I always prefer a tissue diagnosis, tissue confirmation of the mutation analysis. Because when you are doing a liquid biopsy, there every chance that these will be different clones of cells which has different mutations. So some clones may be liberated, some clones may not be liberated, which may not be. So if the mutation is not there in the liquid biopsy, it does not mean that mutation is not there at all. This has to be with the tissue biopsy. Wherever possible, I always try to go for tissue biopsy. And that too, even if it's in the mediastinum, endobronchial biopsies can be easily done nowadays. This has been my experience for almost, after the introduction of this endobronchial biopsy, till now, to tell you frankly, I've never resorted to liquid-based biopsy at all, till now. We have been able to get the biopsy somewhere. Yes, if that is the problem, then there is an advantage of doing liquid-based biopsy. Only advantage with liquid-based biopsy, what I feel, is that it is more pure. It may not be contaminated with other cells, and we are able to extract more better quality DNA. But the problem in liquid-based biopsy is the cutoff, especially if there is an amplification, especially in MET amplifications. When you are doing a liquid-based biopsy, and if you want to use tepotinib for CMET amplification, the cutoff for amplification in liquid-based biopsy is different, and tissue-based biopsy is different for it to be this one. Like, for example, we call it as high-level amplification, which is GCN more than 10, where the tepotinib will act better. But if it's liquid-based, it has to be more than 2.5 or 3. So these differences are there, so that we have to trust the lab for liquid-based biopsy. Till now, I have at least not had much problem in getting tissue biopsies. And as far as the sarcomatoid variant, which you were talking about in the previous, I went through a wrong link and I was not able to communicate with you. Okay. I feel that more of MET amplification is more common. This has been observed even in other malignancies also, other solid tumors. When there's a increased metastatic potential, the MET amplification is more common when compared to exon 14 skip mutation in sarcomatoid variant. Generally, that's what we have seen so far. So as far as second line is concerned, I always prefer a tissue biopsy. There are three things which I wanted to add to this. The advantage of tissue biopsy is there is a chance to note the type of resistance. One of the type of resistance is conversion to small cell cancer.
Yeah.
Suppose if the patient...
So I completely agree. Tissue is the usually preferred method.
Preferred method.
Yes. So, but sometimes tissue acquisition is a problem. For example, two situations I will give, which we very commonly face. One is progression brain alone. Other sites are not have progressed. Second situation, progression bones alone. So these two are actually problematic, and we
I do agree. I do agree. In such cases, we have to opt for liquid biopsy, and if you are able to pick up something there, then well and good. Otherwise, again, we have to see.
Correct.
We have had cases where there was a sudden, in a gap of 1 month, the last PET and the present PET showed a vast increase, rapid progression. When we did the biopsy, it was small. It had converted to small cell lung cancer. From the progression itself, we could make it out.
Yeah. So, Professor Ayers, I would request again your comment for second line situation specifically when the patient is on some treatment for EGFR TKIs, now has progression. So definitely, as we all agree, tissue is mostly favored. But how should, what has been your experience? And as you were highlighting, there is some data which you are generating. So any experience and the data from your lab?
Okay. So if I have a patient which is EGFR mutant, I start the patient on a third generation TKI with or without chemo, then the patient is progressing. The first thing I tend to do is liquid biopsy because it's less invasive. If I find something there, let's say a new mutation, KRAS, BRAF or so, or MET amplification, then I will treat accordingly. If I have nothing that I can target, then I do a tumor biopsy. Indeed, I actually ask for liquid biopsy, and at the same time, I'm asking for a solid biopsy. Because, I'm always having 7 or 8 dates as a waiting list to do a interventional radiology biopsy. So during that time, I have the biopsy, the liquid biopsy result. If it's true, I just cancel the tumor biopsy. If not, I just go on. That is truly what I'm doing. Okay. In my experience, let's say, I'm getting only 50% of the cases. I'm getting let's say, in 50% of the cases that there is something that I can target, only in 50% of the cases I'm able to really get it in the liquid biopsy. Because very often, if it's not very high tumor mass, particularly if it's only thoracic and so on, it's difficult to detect in the liquid biopsy. But, this strategy, I think, is not delaying you and is saving half of the patient from another biopsy.
Okay. So I think as per the situation and as per the individualization and as per the patient agreement and as per the disease burden on progression, all these factors matter. And it is also, as we discussed, physician comfortability and physician preference. So a lot of things play at the back of the mind, and the experiences might be different for different individuals. And as per the situation, we need to intervene. So I completely agree with the comments of both the esteemed panelists. We also try to utilize the situation wherever it is fitting into it. We cannot say it is only either of the two. Most of the time, we try to use both of them whenever it is feasible in the reverse sequence or the direct sequence. So coming further ahead, now we come to a case. This is a simple case of 50 lady, performance status 2, large right lung mass, adenocarcinoma. PD-L1 was 80%, but thankfully patient was not started on chemotherapy and was detected to a MET exon 14 skipping mutations. So there is two situations. I will first request Dr. Arun to comment. The patient sometimes happens that patient has been tested EGFR separately and NGS has been separately, but however, we are now giving up that strategy. Now every patient undergoes NGS. So if the patient has been started somehow on chemotherapy because the patient has performance status 2, disease burden was high, patient was not ready for wait for NGS reports, which sometimes happen when the NGS turnaround time is higher than 10 to 14 days. So if the patient has been started on chemo, whether you will now switch directly to MET inhibitors in this scenario, or you will add IO because PD-L1 is also strongly high in this situation.
Definitely no IO because we know it's not going to work well. But again, if the patient had some response to chemo, I may even continue that for maybe 1 or 2 cycles more. Because of the performance that improves, and we know these drugs are not easy drugs also. They have their own set of toxicities. If there is some improvement in performance status, I feel giving 2 cycles more, that is just 4-5 weeks extra, may not be an issue. Then we can always rescan and then start on the MET inhibitors. That will be my strategy.
Okay, so as per the response, and definitely addition of IO is not so useful as Dr. Arun highlighted. So this is a very important point which Dr. Arun has just highlighted. In patients with MET exon 14 skipping mutation, it is very, very clear that IOs don't work very well. So this is a situation which is completely different from other mutations like KRAS and BRAF, where we know there is some data to suggest that IOs work well. But this is a situation where we know, oh, in MET exon 14, even if you have good PD-L1, unlikely IOs will add much to the value. So it's we always try to switch to targeted therapies wherever feasible. And it is again physician preference when he or she wants to shift. And sometimes the patient had very good response to first cycle of chemotherapy. Patients ask due to the response which they had got, they wish to continue 1 or 2 cycles more and switch later, and it can be done accordingly. In our practice, if it is feasible by cost and other methods, we try to switch to targeted therapies as soon as feasible. This is purely physician preference basis. It has no direct data-based report. Dr. Deepak, do you agree with this scenario? And what practice?
I agree, but see the response rate for tepotinib or capmatinib is close to 60%. So if we are looking for response and a patient is symptomatic, I think these are the best drugs with the best response rate, and I'll inclined to switch to these inhibitors earliest rather than waiting for the second line.
Yeah, that's fine. Pemetrexed plus carboplatin has a response rate of 35%. If you add Bev to it, response goes to 42%. And these drugs have a response rate of 62-65%. So that's very clear. So it's as per, if the patient has already got response on first cycle, so sometimes physicians might wish to continue 1 or 2 more cycles. And patients also will request for the same. So as per the situation, this can be done. So,
in fact, yes, I wanted to add a few things if some students are listening to this. In fact, EGFR, ALK, ROS, and MET, these are the 4 mutations in which IOs does not work at all. In fact, BRAF and other thing, there is some role of IO if there is an associated increased PDL1 expression. But these basic 4 mutations in which PDL1, whatever the percentage may be, the immune checkpoint inhibitors will never work on that. We have solid data for all these 4 mutations.
Well, completely agree. Completely agree. With ALK, there is clear data of 0% response rates. With EGFR, data of only single-digit response rates, similar with ROS and MET as well. Completely agree with you, sir. This is a learning point for all the students who are attending. So moving further ahead, these are the data sets which are available, and the guidelines. It's clear that MET inhibitors are the treatment of choice whenever there is SCOG14 skipping mutation, tepotinib and capmatinib. And now, which one to be preferred? This is a indirect comparison, which Professor Ayers has already highlighted. And I think this indirect comparison gives us some hint, but definitely it is not a randomized data, and we don't expect that anytime randomized data will come in this scenario. So we know. So there are some additional advantages with tepotinib, which we have seen and understood. I request Dr. Arun sir to highlight these points, why if both capmatinib and tepotinib are planned, either of the two are planned, which one you will prefer based on which points do you think?
I think as a practitioner, the main thing is that nowadays capmatinib is not there. We have to ask the company to specifically request that. So I think they have already given up the what is the battle is there or not. So in the practically, I think it is as of now to get capmatinib is very difficult. On a named patient only we can get that. So as a practitioner, I going by the thing, I understand that they are definitely agreed to the fact that capmatinib is the most effective drug. So I will go for that.
Okay, okay. We had a phase 4 trial of capmatinib at our center. So thankfully, we have a good experience, and we recruited the maximum number of patients from India in that phase 4 trial. That is why we have good experience with capmatinib and also tepotinib. Tepotinib is already being utilized in a large number of the patients. So yes, both are good drugs, and the indirect comparison clearly suggests that tepotinib seems to be slightly better, scoring somewhat better over capmatinib. And the most important point, which is important, is that tepotinib seems to have much better intracranial penetration as well. And also, if we see the dose adjustment, because as you were highlighting, Dr. Arun, these drugs are not very easy. These have significant edema as one of the very important side effects. The grade 3 are not so common in the in the randomized data sets. But in real world practice, these are actually disturbing for the patients in around 20% of the cases where we need either dose modification or interruptions. So in capmatinib, the problem is that we have to switch to another dose formulation, that instead of 200 milligram tablets, we need to switch to 150 milligram tablet. While with tepotinib, it's so easy. You are taking 2 tablets now. After the toxicities come down to grade 1 or grade 2, you can reduce the singly from 2 tablets to 1 tablet. So doesn't require to purchase any additional stock. So that becomes much easier in the real world setting. So that makes us to choose tepotinib much comfortably over capmatinib whenever it is commercially procured. So
in fact, when
yes,
this
sir.
tepotinib has one mild advantage over capmatinib, is that other than this regular that it blocks the drug efflux mechanism also to some extent. When compared to capmatinib, tepotinib blocks the drug efflux mechanism, this ABC cassette proteins, and so the intracellular retention of tepotinib is better when compared to capmatinib. This is as far as the this one clinical, not clinical, in the lab, this one is concerned. How effective it is in vivo, we do not know. It's in vitro. The study is there, the Chinese study which has been published. So they have shown this.
So that might be the reason for having somewhat better efficacy, which are coming from the
Maybe,
indirect comparisons, which Professor Reyes suggested in detail. Professor Reyes, again, I would request to give your final comments on this regard. Comparison between the two drugs, though these will be always indirect, there will not be any randomized evidence. In your practice, how do you select between the two?
So honestly, I think it's difficult to say which drug is better as compared to the other, because there is no strong comparison, robust comparison. It happens to me that I've been mainly involved in trials with tepotinib. I'm pretty familiar and I have access to it, so I tend to do it. I think the data are not looking worse, at least. And even I cannot say scientifically they are better. So I tend to stick to that particular fact. In terms of safety, they look very, very similar, honestly, at least this is my experience. So I'm pretty happy using those. If tomorrow I do not have access to Tepo, I will use capmatinib.
So again, it's again a physician preference, and there are some points which we tried to cover were indirect comparisons, easy dose reduction. So these are the points, and I think scientifically we cannot say that one is better or other is better, but it seems that all of us will be slightly more comfortable with tepotinib with available data.
So Dr. Akhil, in amplification, is it if exon 14 skipping is there, suppose post EGFR in MET amplification, is there any preference between tepotinib
in
or
that situation, there is more data set for savolitinib, less data for other drugs. Capmatinib, least data set. Most data is for savolitinib. Second, some small studies are for tepotinib as well. Professor S, do you agree?
Yeah, I agree. So in that case, yeah, I would say savolitinib or amivantamab are the ones with the stronger data.
Yeah.
In fact, the cohort B of this Vision study itself was amplification, where they found that DCN more than 6 or 7, the tepotinib effect is much better. So they classify it as a high risk amplification. If this one MET and C7 fish test is more than 2 or 2.5, or if the GCN value, the number is more than 10, ideally if more than 6. If it is 10 and above, the effect of tepotinib is supposed to be much better. But they have still not published that cohort B data because it was cut short. It was terminated early.
Yeah. So I completely agree. MET amplification is actually more tricky and requires more expertise. It requires more interpretation part as well. And though they are more common than exon 14 as well. So this is the point which is important, and Vishwanath sir tried to highlight this very importantly. And all these points should be taken care. And we agree that toxicity management is an art. And as we get experience of one of the TKIs, all TKIs and immunotherapies require some amount of experience and physician learning curve. And as soon as, for example, as Professor Ayers was highlighting, he had more experiences with the trials of tepotinib. That is why the preference shifts automatically to the drug which one is particularly utilizing. So these points matter in the practice. And it seems that the drugs, this is a class effect of the drug like edema, some amount of creatinine increase, which is not directly due to the renal injury, but due to inhibitor of the pumps, which are pumping out creatinine from the renal tubules, and hypoalbuminemia. This hypoalbuminemia combined with edema is a combination which leads to significant amount of problem with the patients. We have seen significant pedal edema and edema in the hands as well in patients on MET inhibitors. So that needs to be taken care with, and we need to counsel the patients for proper lymphatic drainages and lymphatic counselings for utilizing hand exercises and movements of the legs so that these patients can breathe. So compression stockings might be useful. Lymphatic massages. We have trained our physiotherapists to give a specific train the patients to get this important massage so that they can have reduced amount of edema, because edema is left unattended, it leads to permanent accumulation and more amount of fibrosis. While if it is drained properly, it is temporarily becomes more easier to manage.
Akhil sir, Professor Harris need to leave. He has another engagement, so
yeah. I think we are about to finish. We have covered the dose reduction part already, so I think we are finished. Thank you to all the panelists for very excellent panel discussion and very active contribution for all the panelists, which is a scientific and not only individual drug based. Thank you to all the panelists, and thank you to the Merck team for organizing this.
Thank you very much.
Thank you so much, Dr. Akhil Kapoor and expert panelist.
Now we request Dr. P.N. Mohapatra sir to give the concluding remarks.
Thank you. We have we had an excellent session actually. I sincerely thank all the speakers and panelists for the excellent discussion actually. My special thank to Professor Luis Paz Aris. We know he's a expert in lung cancer actually, and his talks and his expert opinions enlightened everybody. And actually, lung cancer slowly becoming a molecularly treatable, any druggable mutations are there, or others with immunotherapy and chemotherapies. But testing the druggable mutation and proper testing methods, both at actually diagnosis and both at recurrence, is very important. I thank Mark for organizing such a beautiful meeting, which enlightened us and transport the knowledge between foreign speaker and us. Now, over to Mark.
Thank you so much, Dr. P.N. Mohapatra, sir, for the closing remarks. And thank you to our audience and all the faculty who were involved in this discussion today. Have a good night, and we'll meet in the next MedChat session. Thank you.